Good evening. My name is Baravan Al-Kassou. I'm a consultant cardiologist at the Heart Center in the University Hospital in Bonn in Germany, and I'm glad to be here. Well, let me start. GARD, which stands for Genes Underlying Aortic Valve Disease, is not just a research project, it's a scientific network that takes a comprehensive approach to understanding aortic stenosis. Its primary goal is to elucidate the pathophysiology, the risk factors, but also the clinical implications of aortic stenosis, with the ultimate aim of developing pharmacological treatments and improving interventional therapies. So the importance of this GARD prospective observational studies lies in addressing a critical evidence gap in understanding of mild to moderate aortic stenosis. As you know, while severe aortic stenosis has been extensively studied and has clear treatment pathway, the natural history of and clinical implication of mild to moderate aortic stenosis remain less well understood. So this study provides valuable insights into disease progression rates, risk factors, and the impact of AS severity on patient outcomes. There are several unmet needs in managing mild to moderate aortic stenosis. First of all, there's a lack of data on disease progression. We have studies on disease progression, but these are small studies, the majority of them from the 90s. So there's limited information on how quickly mild to moderate aortic stenosis progresses and which patients are at greatest risk. Moreover, there's a lack of risk stratification tools. Clinicians currently lack robust markers to predict which patient will progress rapidly. And moreover, there's an insufficient guidelines for monitoring frequency. You know, while severe aortic stenosis has well-defined follow-up intervals, the optimal surveillance strategy for mild to moderate aortic stenosis remains unclear. So all in all, there's a limited awareness of mild to moderate aortic stenosis, and importantly, limited awareness of the mortality risk in this patient population. Moreover, till today, there's no approved medical therapy, no pharmacological interventions that are proven to slow aortic stenosis progression, highlighting a therapeutic void. While, as I mentioned, the GARD study was a prospective observational study till today involving 307 patients diagnosed with mild to moderate aortic stenosis between 2019 and 2023. All patients underwent an transthoracic echocardiography at baseline and every 6 months, employing qualitative and quantitative assessment to evaluate the anatomy, the function, and to assess the disease progression of the aortic stenosis. And additionally, a biomedical or biochemical evaluation, including markers of inflammation, cardiovascular stress, was conducted at each visit. Moreover, we also evaluated our patients in terms of quality of life and symptoms of heart failure and so on. So the primary clinical endpoint of this study were the progression rate of aortic stenosis, defined by changes in echocardiographic parameters indicative of AS severity over time, and we looked at all-cause mortality in our collective. So we included 307 patients. The mean age of our study population was 74 years, and almost 40% of the patients were of female gender. And of the included patients, 66% were diagnosed with mild aortic stenosis, whereas 33.6% of the patients had a moderate aortic stenosis at the time of inclusion. So the baseline characteristics, including age, BMI, ejection fraction, and risk factors such as the STS-PROM, were well balanced between both groups. The GARD study yielded several notable outcomes. First of all, the high progression rate. We observed in our patients that almost 47 of them showed a progression to a more severe aortic stenosis grade within a median follow-up of 511 days. We couldn't observe any significant difference in progression of aortic stenosis rates between patients with initially mild and moderate aortic stenosis. Moreover, we looked for risk factors for the progression of aortic stenosis. We could observe that elevated phosphate levels and elevated inflammation markers, such as CRP, were significant predictors suggesting that metabolic and inflammatory pathway play a key role in the progression of aortic stenosis. Most important are our mortality findings. Overall, the one-year all-cause mortality was about 7.8%. However, we could observe in the patients with mild aortic stenosis a mortality rate of 6.4% as compared to 13.6% in the patients with moderate aortic stenosis, which was significantly higher. Of interest, our survival analysis showed that moderate AS patients continued to show worse survival at the follow-up time of 2 years. So even when we adjusted our patient cohort for confounders, moderate aortic stenosis still was independently linked to increased risk of mortality in our cohort. The GUARD study provides several practice-changing insights. First of all, we want to shed light on the monitoring protocols of these patients. We have to, the medical staff had to enhance the surveillance of these patients. So given the high progression rate, patients with mild to moderate aortic stenosis should undergo regular echocardiography, potentially every 6 to 12 months, rather than waiting for symptom onset. Moreover, we need risk-based management of these patients, incorporating, for example, biochemical markers like phosphate and CRP into routine assessment may identify vulnerable patients that are a higher risk of rapid progression. And finally, there could be a need for early intervention in specific patients with moderate aortic stenosis, which is associated with higher mortality in specific patients. So clinicians should consider timing or reconsider timing for valve interventions and involve multidisciplinary heart team earlier in the disease course, in contrast to the which is the case now, which the clinicians wait for the patient to develop a severe aortic stenosis. And there could be also a need for patient education. So patients with mild to moderate aortic stenosis should be informed about potential of rapid progression and the importance of adherence to follow-up schedules. While to build upon the GUARD study findings, I think that the following steps are essential. First of all, we need a validation of our results in a larger multi-center cohort. We need to confirm these findings across diverse population and healthcare settings. Furthermore, we need an interventional research. So we need to investigate if targeting phosphate metabolism or inflammatory pathway can slow aortic stenosis progression. Moreover, development of predictive models that are based on evidence could help to identify patients that are at high risk for rapid progression and may simplify clinical decision making. And I think we also need to think about the clinical guideline and to update them. Based on these findings, at least, professional societies should consider revising follow-up and management recommendations for mild to moderate aortic stenosis.